All right, got set up a little early this morning, and what I wanted to talk to our viewers today about is CPR. And not just CPR, not just, while we do certain things, like while we do compressions and while we limit interruptions and why we do airway at this point in time, why we give epinephrine, why we give amiodarone for this, not that. And nothing to do with target temperature management, none of that. Specifically how we get to that point to where we find that patient, that's where we usually are set up for success. A lot of times in EMS you get kind of, shuffled around. You don't get the same partner every day because of workforce shortages. Sometimes you're going to work with a certain person, you're fully expecting that for 12 hours, and you come in and you just get shifted around. It's the nature of the beast. It's anything, everywhere you go, things change. It's not just EMS.
Yeah.
So that can kind of change your whole dynamics of how you're going to do throughout the day. However, we still are afforded the opportunity to prepare. And do you know where that starts? Well, first off, it starts at home. You got to make sure that you get full night of rest. You're ready to go, ready to give usually 12 hours to your patients at minimum. And to be able to do those things for your patients. So it starts there. But I'm talking about the call that we prepare for, such as the cardiac arrest. We're not going to talk about one specific in nature. We're just going to talk about the cardiac arrest comes in via dispatch, however you receive it, with your tones, your MCT or whatever, and it comes over as a cardiac arrest. You and your partner are driving down the road, or maybe you're sitting at the station, but you get the call of a cardiac arrest.
You say a lot of things, especially about eating okay and getting rest, but you also have to leave your problems that you might have from home at home, right at the door, and not bring them into work, because if you're not on your A game and get a call like this, then nothing matters, okay? Or if the call comes in and you have to set aside your stress from some other thing, or the last call you were on, which can also cause an issue, you kind of have to. I think, and we practiced this week with a specific case, I think the pre-plan is the most important thing you can possibly do. It is worse when a patient comes in the front door without EMS and then they code in front of you. No one's prepared. Everyone's running around. People are, doing what, and then we get into a rhythm and it's okay, but we lose precious time by that. And I think you make a point about things that we as ER physicians or ER staff don't think about. You may work with one partner all the time, and y'all are like a well-oiled machine. You know what that person's going to do, and blah blah blah. But if you're shuffled around, you don't know you actually don't even know what they're capable of doing. Maybe somebody you don't work with all the time.
It happens on a daily basis. People get sick. People have to call in. Logistical needs. You need an EMT working here. You need a paramedic working here. You need a critical care paramedic working here. You gotta make changes. You gotta adapt to it. But the one thing that we can do is prepare for the cardiac arrest, no matter what the partner is. But we gotta take it serious. And in order to do that, you've got to do it from the time of notification.
Yeah, that's fair.
You got to do it from the time of notification.
Like en route there.
Yeah.
You're having that discussion.
For example, I worked a shift with someone one time, and we went to a cardiac arrest. So when a cardiac arrest, I'm like, I look at it, everyone's viable. Everyone's viable. The notes don't really mean anything to me. Everyone's viable until I can get there and prove otherwise. You're right. This means war.
It's a fair way to look at it.
We're going to war.
Yeah.
In order to go to war and to win war, or to be successful in war, you got to go in planning. So anytime that ding comes across and I look at it and it says cardiac arrest, this means war.
Sure.
And I have to start preparing. Got to start preparing.
Right.
So I look over at my partner and I say, hey, this is cardiac arrest. It's right around the corner, wherever it's at. Trying my best to navigate them how to get there. You're actually the lead on this call, or you'll be writing the chart. I'll help you. Obviously, we'll be doing this together. But what would you like me to do? Let's go ahead and start assigning roles. And they look at me and they say, cardiac arrest, and I confirm the address, and they're like, yeah, and they said, cardiac arrest things. And I said, we're going to lose. We're going to lose.
Right.
Because what happens there, and specifically when I bring this up, and I say cardiac arrest things, and we're going to build into this episode a little bit further, but what is that going to set up? So cardiac arrest things, that we know that we were both going to do that anyways. It's not telling me a thing. It's not telling me if you want me to secure the patient's airway because maybe I'm better at it. Maybe you're having a bad day when it comes to airway. Do you want me to secure the IO access? Do you want me to run the monitor? Now I get on scene and I assume I'm going to just be doing cardiac arrest things. So I'm going to go to the one that I want to do, despite what she or he was doing at that point in time.
Yeah, I think that's fair. I mean, you don't have any idea. You have a menu to pick from, but you basically haven't been directed anywhere. I think, when luckily, not all the time, but when EMS gets called for cardiac arrest, fire will be there before y'all most of the
Right.
time. And I think, it's helpful to say, don't leave. We may need you to drive us in somewhere. You continue bagging. You're doing a good job. Or, hey, you're not doing that great of a job anymore. Thanks for doing chest compressions. Let me rotate in on that. And but of course you need one leader. The problem, I think there's several fold here. The problem is when there's no leader or two leaders, and then you can't follow which way to go or what's going on or who to listen to. And the other thing is not having that plan. It would be, I think, a better way to have that conversation, besides you starting it off, would have been like, okay, Michael, you take the airway, however that looks, whatever that means to you. I'm going to put the pads on the patient, or my monitor on the patient, whatever. And then we can reconvene. I'll do IO access, or you do IO access if you finish the airway, whoever finishes what they're doing first, and then we'll go, from there. I think that's helpful. You also, once you get on scene and you look at the situation, might call for backup from somewhere too.
Well, specifically, let's talk about the demographics in this area right now. And so we've got to the point, we received the cardiac arrest, we have two providers in an ambulance, maybe a student, maybe a third rider, but let's just count on two people in the ambulance. We know that fire department is probably going with us, so we're going to be there and we'll see them there. We really don't know their scope of practice. Some of them are EMT trained, some of them are DHEC first response fire departments, and then some of them are typically a first response level fire department. So that right there is a mystery to us in itself.
Sure.
So that makes us wonder, because if they're a EMT level fire department that has been working this cardiac arrest, we could assume that they be there, especially with 3 to 4 people, with compressions going on, an AED attached, and maybe an IGL or a King LT.
Sure.
So we have to recognize the dynamic. So there's a conversation. So we need to build off of it too.
Right.
Because we can't just go in and say, all right, Sarah, you're on airway, because we know that needs to be done on a cardiac arrest. We need to refine those conversations and say, hey, such and such fire department is responding with us. If they have secured the airway, I'm going to actually put you on drugs. We will leave that airway in, evaluate it. As long as it's okay, we'll leave that in, and we'll put you on medication.
No need to change that out.
But what if I specifically say, Sarah, you're on airway, and you say, copy, I'm on airway. And when we get there, fire department has a IGL in, and the end tidal is at 35, and they're backing with no issue.
Then I come back to you and I say, Michael, there's an IGL in place. The end tidal's 35. They're bagging with no issues. I'm going to let them continue for now.
But you got to have that conversation.
Got to have that closed loop.
But if we just establish that we're going to do cardiac arrest things, you can see that stuff would get missed.
Sure.
So we have to evaluate for changes too.
Sure.
Because not all the time when we pre-plan everything that's in the truck is actually what we're going to get when we get there. What we expect when we get there is that two people doing two-person CPR, and we're going to step in with our ALS interventions. And that's not the case most of the time. get there, reevaluate the IGL if it's been placed. It's correct. Good lung sounds. End tidal's good. Let's go ahead and slide you to a different position. We got to do that very quickly, and we got to do that with closed loop communication. So all of a sudden, Sarah, that was going to do airway, Sarah, I looked at the IGL, got good lung sounds, good compliance with that. I'm going to slide you over to medications, all right? And
Copy.
Yeah.
I'm going to go to medications.
And you understand. We're going to medication. So realistically, we have all the tools on the ambulance to provide a high quality resuscitation. So what is the cause of when we go through and say, that just didn't work? What happens? That just didn't work.
Well, miscommunication is part of it, right?
Okay, yeah.
Miscommunication, not communicating,
Okay.
Could be another thing. And then, what I have found from picking apart stuff are a lot of personality stuff.
Yeah. We have different personalities. EMS does, so to speak, and I think some things are important to providers, and some providers have read evidence telling the lack of importance for that. So I really still think there's some personal feelings there. I mean, have you ever been part of something to where you're just always do this, and a close provider that you work with is like, take it or leave it. You know what I'm saying? Like specifically, let's talk about manual versus automatic blood pressures.
Mm-hmm.
Like me, I'm like, it's 2024. These machines are great. Let me put you on automatic blood pressure cuff. And then I work with paramedics and say, you need to make the first one manual. I'm like, okay, we'll take one. There's certain things that are important to certain providers, and I think that can kind of get in the way too. And I don't really think that anybody doesn't know what I'm talking about here is endotracheal intubation.
Oh, yeah.
So that I'm specifically talking about endotracheal intubation with a cardiac arrest patient.
We don't need that right away.
Yeah, well, we're not going to talk about it right away, but that's what I'm specifically talking about,
Yeah.
So, but yeah, we can dabble into that here in just a little bit. When we come back, we're going to actually talk about some things that we have found that work for others, and then we're going to maybe look at some things that have worked, but some people have had issues with, and to see how good those devices are, we'll see when we come back.
Okay. All right, we're back, and Mike has a graphic to review the team approach to CPR, and this is certainly something we discuss in the ER, but it's not always done as eloquently as this picture describes, but it's a good idea, at least from the pre-hospital perspective.
So this particular picture here actually goes in, and it has a total of 6 providers. That in itself is going to be questionable, because sometimes you get 6 people, sometimes you get 8 people,
Sure.
and sometimes the patient arrests right in front of you.
It's just you.
And that's where you have to allow the logistics to come into play. You have to call for backup and things like that. So this is not something that you're going to be able to set up on every scene right from the beginning, because let's just say you beat the fire department. You're literally a street over, and you're on top of this call. So you're having to set that up without 6 people. So we need to know the most important steps that we have to continue to do. So let's just say me and Sarah are working together on an ambulance, and we get a call for a cardiac arrest. We know that we're very close to that patient with less than a 2-minute response time, and we're also already in the truck. We hit en route, I navigate her to it, we try our best to assign roles, I tell her I'm in charge, she tells me that when she gets there, she'll assume airway, and we walk in, and it's just the 2 of us. So what are we going to do?
You're going to take over, or I'm going to take over airway, getting a BVM applied with some oxygen, and you're going to start chest compressions.
Yeah.
That's it.
It's that simple.
That's it. We'll get to the rest in a minute.
Yeah. So the thing is you you're not getting to pull out your biad, your
No, none of that
stuff.
matters.
You
You're going to
need
bag them, and you're going to do chest compressions, and you're not going to stop.
Right.
And then when we need a break and we switch, we switch. And then we'll get more help. We call for help right away.
And we're going to do that at 30 to 2, right?
Yeah.
Because we don't have an advanced airway,
Right.
and we're having to swap back and forth.
Yep. It is what it is.
So we need, because I feel a lot of times if we were to go into that call, knowing that we have to drill the patient, we have to get access, we have to intubate the patient, that we are going to start continuous compressions. If it's me, I'm going to start continuous compressions, and you know I'm right, while you're getting the iGel, the King, or intubation equipment out. You know I'm right.
Sure.
But we need to go back to that standard of the HA standard of when you have 2 providers that show up. The important things until we can start to allow this more infantry to come in. You're like, oh, I did that because I meant this means war. So more infantry to come in. But specifically, it's the 2 of you. The two things that we can do is the most important is continuing CPR and early defibrillation. So in hand with your ventilations, you can come around me and put
Sure.
the AED pads on. But at that point in time, we're pretty much stuck, right?
Yeah.
We're pretty much stuck. So we're rotating, and we allow this scene to come on dynamic. And fire department is sent. And fire department is sent with maybe an engine of 2 people to 3 people. Let's just go 3 people for easy measure. So at that point in time is when we can start assigning roles. We can start, taking them, put them in what we were doing to begin with, the most important thing for the patient. And that way, based off of scope of practice, we can go ahead and start getting some ACLS medications going. We can go ahead and start getting an airway in. So we know after that airway, we're going to go ahead and start with continuous compressions, but not until then. How many EMS crews do you think actually go out with 2 providers and they're there with 2 providers and still perform 30 to 2 CPR?
They probably don't.
They probably don't.
I think even if you started and didn't do the bag valve mask and just started continuous compressions and you got like your mask out and gave 2 breaths or whatever, a breath or 2, and then got your King or iGel or whatever and shove that in there, like, okay. Like, I mean, I could see if somebody was going to do because the chest compressions are the most important part,
right?
Basically.
Right.
So that's not also a bad idea either. But doing other stuff doesn't really matter.
But let's just think. You go in, you're looking for that iGel, you're lubing it up.
No, it's a whole thing.
Yeah,
100%. I don't disagree with you.
It's not that it can't be done, but everything that you're doing is distracting, where you should be the next. So let's just say you're getting that iGel lubed up or you're taking it out of the package and that provider's on their 4th set of compressions.
Right.
We know
well, we teach the lay person hands only CPR, no airway.
We know that the next cycle of compressions they should be swapping, right? Because of rescue or fatigue.
Sure.
So even though something like that should kind of seem innocent, it could seem done pretty quickly, it's still taking away from the little bit of the confusion. I think you've got to allow the infantry to come in until you start going back on your plan. And we need to really be thinking about compressions and ventilations until we can get more help taken over.
Right.
The thing is if we go in and all right, so let's just take this situation here and we say, okay, pause. All right. Instead of doing compressions and ventilations, let's just go ahead and get everything else ready for when everybody gets here. So I'll go ahead and drill this patient. I'll go ahead and get the epinephrine out, and I'll go ahead and intubate the patient. That way, when they get here, start pumping on the chest, it'll be much easier. We can at least confirm that we have an endotracheal tube. 5 minutes later, everybody lines up. We put them into play, and we got a dead patient.
That's fair. I mean, now, circling back to what you had, certainly I think the most important part, besides having that pre-talk of assigning roles, is calling for backup, right? That's important too. The other question I have for you, Michael, and I've always wondered about it, is why when let's just say you're en route to the hospital, somebody with chest pain, and they code in front of you. Why do y'all pull over to the side of the road and not just continue towards the hospital?
Because I can't do CPR riding down the road.
Why not?
Because the driver is probably going road bumps. It's not effective. I can't really use my time approach. It's just my whole dynamics are messed up.
Okay. But what if you know that person was having a STEMI and they really have to get to the cath lab? The time is of the essence. How long do you wait at the side of the road?
Until I get them back for 25 minutes. Because it doesn't matter, even if they are having a STEMI, if they're in cardiac arrest, when I can't return them, and get, pulses back, what are y'all actually going to do with a blockage?
So I think, and I don't disagree with what you're saying, just to begin with. I don't disagree with what you're saying. Yeah, thank you for clarifying that, Michael, because I think as a physician, we just don't understand why they don't come right away. Now, I want to talk further about this because I've just got a lot of interesting thoughts about this. So let's talk about these Lucas devices and these mechanical CPR devices. It sounds like by and large people like the Lucas more than the AutoPulse. The AutoPulse, I thought did a better job in some head-to-head comparisons with the Lucas, but it also has its downfalls, like any of these do. Are they perfect? No. Do they free up the provider? Yes. I don't think. I'm guessing the literature doesn't show they do anything with survival. Is that true?
No, I mean you can dabble and you can look into a lot of different studies, and I don't see that evidence out there. Maybe I can put some of the studies that I've looked at. So realistically, the advantages that you're going to get is that it does automated chest compressions, allowing for complete chest recall with this suction device that is on there.
Yeah.
So that is. That obviously we know that human compressors sometimes do not allow for complete chest recall. The device is designed to where with the suction cup in the middle to be able to pull the chest up in the compression for complete chest recall. The other thing that we do know is that as long as the battery is charged, that they provide the same amount of compressions, no longer how long you're going to work the patient. So they're really not experiencing that rescuer fatigue that we know today is a real thing. Okay.
Well, the other thing I think that is interesting and people bring up a lot is a couple things. Can it be misplaced and do damage? Well, sure. Your hands can be misplaced and do damage too, right? Then the other thing is how long does it take you to put on there? Now, in a team effort to highlight your team approach, you need to discuss this while you're doing CPR and say, we're going to get ready to place it on the next round. On the next, pulse check, we're putting the board underneath.
Uh-huh.
And then we're going to continue, and you're going to latch it on that side. And on the next pulse check, we're placing this. Right? I mean, that makes the most sense. Now, I've talked to people that said they have brought a patient down 2 flights of stairs over their head on a backboard with a Lucas going because they did not want to interrupt. That's how it should be done. It shouldn't be a prolonged interruption.
No, I agree. Let me ask you a question. So, do you guys use them in the hospital?
Yes. Not all the time. Not all the time. Yes. And I'll tell you when we use them. Usually. 2 cases. I think this is a massive PE, and I'm going to give lytics, and I know that commits me to 1 hour of CPR time.
Okay.
The other one is with ECMO, and that is going to be a game changer in this area. And I mean this area, I mean upstate South Carolina, because other places have been doing it for a while. We're a little behind the times here with that. Not that we don't have ECMO. I'm talking about eCPR, emergent ECMO.
Okay, well, if I bring in the cardiac arrest patient,
right,
and I have not achieved ROSC, but I've had multiple rhythms. I've had VFib a couple of times, so I've obviously continued transport. We're going to the hospital. I'm making my transfer of care. We've been working this person for 30 minutes, and I put them on your bed, do you ever think about putting on Lucas device?
I have when someone else brings it up to me. Like when someone says, do you want to use the Lucas? I'm like, oh. And then I think through in my mind, what are my next steps in this patient? Like, was this a STEMI that coded? And I'm like, I got to get this person to the cath lab. Is this someone that's ECMO appropriate? And I will touch upon that. We'll discuss that. I think the other thing that has to happen is we have to have a buy-in of using, if we think, and I'm not, to be 100% clear, I am not saying that ECMO is a magic fix. It's not. There'll be people that die from it, even if you tried it, that die from, and they got ECMO. There's a very specific criteria that patients have to meet to be even considered for it.
Okay, let's flip that coin then. You're dealing with someone, they're pretty sick in the ER, and you're, maybe whatever interventions you're doing for them, I'm not going to specify that. I could spend a lot of time going into that, but this patient's pretty sick, maybe on a pressor or two.
Sure.
And he is not stabilized to go upstairs. You've been watching him all day. The next thing, you have a tech come running over to you and says, hey, the patient's not breathing. And you go in there. Do you ever think about a Lucas device thing?
No, because it's just not in my wheelhouse all the time. But maybe it should be. If I'm going to commit to a while of being... Now, I can't stand the not stable enough discussion. When will they ever be stable enough to have an intervention done?
Right.
When's it going to happen?
Right.
They have to go to the cath lab if it's a STEMI.
Yeah.
If it's a blocked artery. I'm not going to fix that.
Right.
Nothing's going to fix that. Now, could you give lytics and circulate it? Sure.
All right, so what you're telling me is that the Lucas device is in your arsenal, but it is situational based.
I think so. And I don't know if that's right or wrong.
No, I don't think it's wrong, because you do see a lot of education that goes to who, what, the when of who gets a Lucas device.
Now, I do think they're creepy. They look like the patient's holding them. It's weird.
They are. And they take some training to get it right. And that's going to be the deciding factor for me. So I guess if I was ever transitioning to a Lucas device, I would first off say the person that's placing it, I would say, are you trained on this device? Do you know how to apply this device in less than 10 seconds? And they say, well, I say, well,
you're not the one.
Going to hold off.
Right, you're not the one.
And we're going to continue compressions. We're going to rotate rescuers.
Until we have someone that knows how to place it in under 10 seconds.
And if we don't, then we're going to continue it this way, because we know that any amount of time off of the chest definitely is lowering that chest compression fraction. And those are the things that save people's lives neurologically intact. I think they're great devices. I love them. But I gotta have someone that knows how to place them.
That's fair.
Right away, and you should see some of the end titles on these patients with it. Prolonged downtimes that this device creates. It's amazing.
Well, I think that's all reasonable, and I think we will do a more thorough discussion on ECMO, but I just wanted to highlight a couple things because we actually had 2 cases in the last 2 weeks in the ER at Memorial, and I know you're like, what? Like in the ER? Yeah, in the ER, because there is such a thing called eCPR, and so let me just read you some of these criteria, because this will be a discussion on the streets of EMS, certainly, because this is a not commonly done thing here. Yeah. So, age less than 70, witness cardiac arrest. Fair. I mean, you can't just have somebody that was laying there. Time from arrest to CCPR, the no flow interval, less than 5 minutes. It basically has to be a witness cardiac arrest, and they started hands-on CPR. Okay. All this makes sense to me. Initial cardiac rhythm, a VFib, pulseless VTAC, pulseless electrical activity. Now, that's interesting because I think that makes sense. But I also had a case recently where it was asystole, but the person was young. It's just food for thought. Time from arrest to the initiation of ECMO, less than 60 minutes. That's why you have to move. So I'm telling you this for a reason, right? I'm going to get back to it. End tidal, greater than 10 during CPR. Okay. intermittent ROSC or recurrent VFib. That's like VFib you can't get them out of, the refractory VFib. Presence of signs of life may predict survival, but these are not necessary. These are just not all. You don't have to meet all of these.
Yeah.
Absence of previously known life-threatening comorbidities like end-stage heart failure, COPD, end-stage renal failure, terminal illness. That makes sense. Like, you're not going to put somebody on, right? And no significant aortic valve incontinence that you really know about.
Mm-hmm.
Okay. So that being said, how does that dynamic change? And this would have to be screened quickly in real time. Meaning, you call me from the field, you have a 40-year-old that went down, CPR was started right away, you've been doing 3 rounds of epi, so now you call me and you ask what the hell to do. Now we have to transport this patient because they have to get there.
Right.
That's why I asked you about the transporting and why if they code on the way to the hospital.
Well, I mean...
And you work them on the side, but you still have to keep in mind that you've got to get... So then this would be a good person to have the Lucas on.
With all due respect, I mean, that has to be something that a physician would kind of, say, hey, this patient does, based off
That's
of the
correct.
Story, that if you could continue transport while providing resuscitation, that this may be good for this patient.
And that's what I did this past week.
Yeah, because because of what we are trained, that we are trained to pull over.
But that's the reason. You are trained to pull over, but there's a reason for this. And the reason for this is the studies have shown it's better that way.
That's going to be a
tough case. These are not going to be like every CPR patient you have.
And the other thing is, as we learn more about this is going to have to be passed down through education.
Oh, 100%.
And if we end up one day, editing the way that we perform, aggressive resuscitation in the field, especially when we're in the back of an ambulance, it's going to have to come down through education.
Or maybe you have to call and be like, I need that Lucas device. I need a Lucas device here because I think this person meets some of these criteria or could be considered for ECMO or blah, blah, blah.
Yeah.
Yeah, there's a lot. So it's just interesting. So
That is cool. Because some of it I understand, but the biggest thing I take away is the time
that
they got to be there.
It's important.
And I know that that's going to be scratching it's going to be right at the cusp, even if everything goes right.
It's going to be a tough case.
So, but
anyway.
That's pretty cool. And I think what we'll do is like a 2-parter here.
Sure.
Because we probably need to dabble a little bit further into the research on the Lucas and the
I think that's great.
Pulse, because I just don't feel very prepared to give you an answer if I would go or if I would know.
Between either one or just, I think that's
As
fair.
of right now, I'm thinking I want to be doing the CPR. I look at myself as an automatic Lucas anyways. I'm going to give you the best 2 minutes you ever got.
Sure. Can I tell you something? This past week, I had a patient that I did CPR on. That's right. Think about that.
Yeah.
Because it's a long story. It doesn't matter. But here, guess what I did yesterday?
What'd you do yesterday?
I said to my friend, my stomach hurts. And not like I need a Tums. My stomach hurts like I've done 1,000 sit-ups. And God knows I don't believe in any workout. So I haven't done 1,000 sit-ups. And without skipping a beat, he goes, yeah, did you do CPR this week? And I was like, oh, I did do CPR. I was like, yeah, that's what it is. And I was like, oh my God, that's what it is.
Yeah, it's
got my ab workout for the century.
It's exactly what it is. And I am a person that, I'm not saying I don't believe in Lucas devices. I'm telling you that I am on the side currently of manual CPR done by a human.
Okay, so I would like to...
But I don't know enough yet to change my mind.
On part 2 of this, I would like to compare manual CPR to any of these devices. I don't care which one. Yeah. Both, whatever. Any device. And then compare the 2 of them and see what we get. I also would hope that our listeners could weigh in on their thoughts on it. I think that would be interesting.
Oh, they absolutely can. When we go back, though, and kind of concluding this thing, we need to go back to the CPR procedure with a team-based approach, because that's been pretty much the basis of our conversation today. We started with me and Sarah on this arrest, and we refused to let anything else take us away from what
we're going to keep going.
Sarah started bagging the patient. She has since moved to compressions. Now I'm bagging the patient
Yep.
2 breaths every 30 compressions.
Yep.
And all of a sudden, here comes the fire department.
Praise Jesus.
Fire department with 4 people, one that is an EMT.
Yeah.
So we were able to let the dynamics come into play. The next thing that we need to do, we need to be thinking about, is we need to be getting an advanced airway.
Yep.
We need to be getting an advanced airway. So whether it be that fire department take over the compressor.
Oh, they're going to take over the compression because they're usually.
And that makes sense.
We just need a break from it.
Yeah, that makes sense. Go ahead and take over compressions.
Right.
And then
you take over compressions, and Michael, you keep bagging for a second, and then I'm going to get that other EMT person from the firefighter. Like, hey, can you get an airway ready for Michael? Whatever that is.
So you're the lead now. Now we're doing cardiac arrest things. Now we're able to make those assignments.
Right.
But think if we would have thought that we were going to have all this help, how we would have had to change that when we went in. Because what if you would have told me going down the ambulance, instead of saying, hey, we're going to do cardiac arrest things, Michael, and I said, okay.
It would be a disaster.
What if you would have said, hey, you're going to do medications when we get there? And we get there,
and there's nothing.
And
I do medications, and no one's doing compressions, or I do medications, and no one does
and
airway.
He's dying, So
and the basics are left aside.
So we have to allow those to come into place. So that third guy comes in, and he actually takes over compressing, and now you have the other guy that's doing an airway. And I noticed you said the EMT, so I guess you're going to have him put in a biad,
Fine.
right? iGel.
No, we don't need to intubate him right now.
we got to get control of this thing.
Yeah,
right?
let's just start there.
All right, so let's look at patient or position number 4. Looks like you've already kind of taken this over. This is usually the team leader.
Sure, it could be you if you wanted to.
Well, it looks like this was your call, and it sounds to me like you're doing a really good job of closed-loop communication. I think we should keep it there.
Okay.
All right, so it looks like you're the team leader. What does that mean to you? What are you doing?
Okay. Well, usually as team leader, at least in the hospital setting, but definitely, I guess, in their setting, I'm going to have my hand kind of on the femoral pulse because I want to make sure that the compressions are going well. Of course, we could have the pads on there that tell us how good the compressions are. I'm going to tell them, hey, you guys switch out every 2 minutes, and there'll be several of them kind of lined up, maybe 2 or 3 people there. That guy's getting control of the airway. Good. Are you able to control that? Michael, can you do medications and keep time for us now that we're able to start medications?
What about, because there's 2 other people, what are you going to do with them?
They're in the rotation for the compressions,
Good
I
job.
think.
Good job.
Yeah, I think.
Good job.
And they could be putting pads on and doing, other little things if we need them to.
When you're looking at the monitor, what tells you that we're doing a good job?
The end title.
End title, where do you want it?
Realistically?
Yeah.
35, but...
So you know what the minimum standard is?
10.
10.
Yeah.
10 is the minimum standard. So anything over 10 has been known to be acceptable. However, if you do see 35 and now all of a sudden
we should probably do a pulse check.
10...
Oh, then we're not.
And now all of a sudden
something's
you see
wrong.
10, you might want to look at maybe that might not be our next compressor. Maybe he was working out before he got the call,
Yeah.
So maybe he's not just doing the best. What about, what else are you looking with the end title?
Well, we could get Ross back, right, if it shoots up.
What else? Confirmation of 2, making sure. Because those supraglottic airways are notorious for slipping off of the glottic opening. So making sure that we're continuing to ventilate that patient. You already spoke to the fact of the spike in end tidal. We've now got we think that when we do get ROSC and we get that spike in end tidal, we got cardiac output along with simulated cardiac output with compressions, and now we should have a spike in end tidal. However, the Lucas devices, they already generate a pretty high end tidal. It's not going to be as obvious as manual CPR.
Yeah,
We're talking about jumps from 20 to 60, where when it comes to a Lucas device, a lot of times you're able to get end tidal upwards in the 40s. So you don't see that huge spike. But when you do see that spike, please remember to continue your 2 minutes of CPR.
Oh, yeah.
Please remember. All right, but you got these other 2 people. So what can they do? What can they be doing?
Gathering history.
Gathering history. They can be, They can be also thinking about if we need to get out of this house.
Sure.
Especially to speak to some of the things that you've already talked about today that we don't even know is going on. Some of the things far as maybe they can take and make sure that we have enough medications to completely run this resuscitation. At minimum, we want to make sure we have 4 code doses of epi, probably some amiodarone on hand, maybe naloxone, I
Sure.
don't know. Probably some D50 just in case.
Sure.
But then again, we can probably use them later on into the arrest for crossing out H's and T's.
Yeah, fair.
Yeah. But we got to allow that procedure to come into place. We got dealt a hand to where we got there, we had no help.
Yep.
But we didn't take our minds off of what we needed to do. And the only thing we were able to do at that point in time is provide high quality compressions with ventilations. That's all we could do.
Right.
But I'm telling you, most EMS crews go in with 2 people. They're looking for an iGel. They're looking for an IO. Meanwhile, compressions may or may not be being done. It is because of what we think is important, and we're all trying to get this patient back. We're all trying to win the war. But you've got to allow it to take place.
Right.
So, the next time you look at a cardiac arrest and you think this means war, just know that you got to establish an army before you can go jumping off of what
I think this is
absolutely
great.
has to be done.
This past week, I had a case that I literally, I did get my army. We had a meeting as soon as I hung up the phone, and I said, guys, this is the kitchen sink case. Everything. We're doing everything.
Yeah.
Be prepared.
Yeah.
And we actually assigned ourselves roles. There was 2 attendings there, so I said, you take the lower half, we'll take the upper half.
Good for you.
We did. We had a discussion about it.
Good for you. No matter what, I don't know anything about specifics of your patient, but no matter what, you were prepared, you had a plan, and you went to battle.
I did.
You're not always meant to win every battle.
I know.
But what you are always meant to do is to perform at the expectations of every battle the same way. And you can't control clutter in houses, you can't control manpower, but you can control calling for help.
I also think, just another one-liner before we end this, is to keep your cool.
Yeah.
If you don't keep your cool,
it's
a disaster.
It's a little harder said than done because, we all get emotionally involved.
Everyone gets emotionally involved.
We love you, and we appreciate everything you do for us. So the next episode, we'll be breaking apart some of this Lucas data to see if these things actually work. We know they work, but to see how
effective they are, right?
And then what we can also do is we can let Fabiano talk a little bit more about ECPR. Obviously, we're going to tell you to follow your guidelines, but it is neat to see that some advanced things, especially coming to the small town of Greenville, South Carolina. So.
Stay safe.
Yeah. Appreciate you.